Good morning, everyone, and thank you for joining us here for the fifth of these Spotlight events in this series. And I think we've got a really exciting one for you today. Certainly, everybody at the Christie Charity and on the clinical team are super excited about what's coming in this event and what will shortly be coming to the Christie. So, my name is Bod Buckby. I am a trustee at the Christie Charity and a patient here at the Christie. And today we'll be looking at a project which we're delighted to be helping to support here at the Christie, which is a new total body PET CT scanner. And in the world of sort of imaging and helping to diagnose and create patient treatment plans, these really are the state of the art. So to give you a sense of this, this will be the first machine in England outside of London to come into operation, and it really will be transformational for what we're able to do at the Christie. So I'm delighted to be joined by three guest speakers today to tell you more about the scanner. And first of all, we have Dr. Prakash Manoharan, we have Dr. Heather Williams, and then with his story of his experience of being a patient at the Christie, John McCormick. So we are really pleased to be welcoming all three, and I will now ask Prakash to come and start the event. Thank you.
Thank you for the introduction, Bod. Morning, everyone.
Morning.
That's me and Heather. Thank you for coming today. It's quite important to us that we're all here together as a team. So I call this Team Christie or Team Manchester. And amongst you, there are healthcare workers, academics, patients. I consider all of us being patients. So this is clearly a teamwork event for Spotlight for the charity. So we're going to talk about total body PET CT, but I'm just going to set the scene, give you a bit of background. Heather's going to get into the details of it, and then we're going to talk about some patients, published data, not our patients because we don't have the scanner yet, and then John's going to talk about his experience here. So what's the impact of the Christie Charity on patient care in Manchester? So this is an imaging focus, looking at imaging and how it actually influences patients' pathway and how it actually affects patients' care in this hospital. And then I'm going to give you some examples of what's actually happened within the Christie for you to actually make this a great place to work in. So before I start, just a little bit about myself, because I was told that this is a requirement so you know what I actually do. So I trained in Bristol, down south. You can boo now. I did MRCP first, so I trained in medicine. And then I trained in radiology. And then I trained in nuclear medicine. And then I came to the Christie. So from the time when we go into medical school to the Christie, I've spent 17 years training to become an expert at what I do. So it's a bit of a long journey. So my specialist training happened in Leeds and the University of Michigan in Ann Arbor, Michigan. And I worked with the person who invented PET, Professor Cool. So that was quite inspirational. He used to sit in the office behind me, and I used to have chats to him. And this is the guy who invented most of what we are going to talk about today with regards to nuclear medicine imaging. He, when he went to medical school, already had a grant to do the engineering development on SPECT CT. That's pretty impressive for a 20-year-old person to get an NIH grant to actually deliver this technology to humankind. And so I do miss him. He's passed away now, but he was very inspirational. So I did not just PET CT and molecular imaging, I also trained in therapeutics. So I also treat patients with nuclear medicine therapy. So it's using nuclear particles. Sounds very dangerous, but actually well controlled. And we're one of the few centers in this country that can actually do this sort of therapies for patients. So I started here in 2007 as a consultant radiologist and nuclear medicine physician. And I subspecialize in oncoradiology, which is cancer radiology. Neuroendocrine tumors are quite dear to my heart, and also hepatopancreatic biliary diseases, which is the other group of disease that I work with. I was appointed as an academy director at the Christie in 2016. What does that mean? That involves teaching and training other doctors and staff members in the techniques of PET-CT and many different aspects of imaging. I also lead the delivery of 70% of the NHS contracted activity of PET-CT, and we've got team members here from Alliance Medical who actually help the country deliver this technology back to the patients. And I also lead the imaging research forum here at the Christie, so we have a lot of collaboration. So when I'm talking here, I'm actually representing a whole group of people. It's a link between all of us. And my main interest in research is molecular imaging and functional imaging and looking at early biomarkers of response. What does that mean? When we give you some sort of treatment, can we use imaging to work out whether the treatment's worked? Can we find out whether that treatment's worked early? And if we can we then change or actually just keep with the current treatment that you're currently on? So it's quite an interesting part of work. So why invest at the Christie? Some of you might recognize this. This came out a few days back. This is our current league table of hospitals in England. I don't quite like the methodology. It's comparing apples and oranges. You cannot compare a cancer centre with Manchester Royal Infirmary. They are apples and oranges. However, if you dig deeper, this is me sticking it there. This is the cancer centre rankings in the country. I've been saying this for 20 years, but now we have a ranking system. We outrank the Marsden and the Clatterbridge, which is quite a phenomenal amount of work that's taken for us to get here. It's from years of dedicated investment in our services here, and actually working with patients. That's a key aspect of it. And why is this important? Because we want to have the best cancer centre at our doorstep. And that's why we have this sort of forums to try and improve patient access to cancer care. And I now have the data to prove that these investments work, because we're top ranked. I'm going to love going to the next meeting where the Marsden sits in the crowd, and I'll put the slide up. Because this is how to inform people that investment in your communities help. There's a slide later on where you'll see about the building across the road. It's called the Patterson Research Building. Why is that such an important building? By building that building, we get to keep our academics here in Manchester. They have the opportunity to actually expand their career and give back to the society in Manchester. They don't need to go find other opportunities in Edinburgh or London. They stay back with us. So these investments are quite key. And I hope that ranking, which is apple and oranges, but for cancer centre, actually clearly states that we're one of the best cancer centres in the country. So what about patients? All of us in the middle there, the colourful bunch of patients. Patients go through many different investigations. There's no one scanner that does it all. I mean, that's like the magic bullet. It doesn't exist yet. So we don't have a scanner that can do it all. So patients sadly have to go through many different scanners. So the CT scan is what I'd say the workhorse. It basically gives you a diagnosis of what's actually happening or an early initial staging. Patients who need fluoroscopy, which is when we do interventions on patients, that's also required from time to time. MRI scan is a very complex, I'd use the word complex. I try and tell people, CT I can explain, PET-CT I can explain, MR is magic. Think about it, magnetism creating images. And the only way I can teach magnetism to my trainees is say it's magic. It's pretty clever that a magnetic force can create images for us to look at. So, because the physics is very complex. So MRI scans, we have them here as well. And last but not least, it's the PET-CT. So if you see there are two words to it. There's a PET, which is positron emission tomography. Heather's going to go through that in absolute detail, and a CT scanner. So it's what we call hybrid imaging. This is where we currently are. We've taken two technologies and literally put them together in one machine. So that one machine can do both jobs together, which is pretty impressive. It's taken a PET scan and a CT scan and made it into hybrid imaging. And this is the world we're currently living in. Hybrid imaging, so the patients have less of appointments to go to, and we actually get more information from putting this imaging together. So this is the kind of travel that patients go through when they come here. And when you say, oh, I've just had the scan before, why do I need another scan? There are reasons behind that. They each function slightly differently. So I do apologize that you sometimes might have to go through all four of it, but there's a reason for it. Hopefully it'll be only three because the CT and PET now is combined together. So what about the examples about how we've come about developing this imaging arena, I'd say, for the Christie? Because when I first turned up here 18 years ago, we were nowhere where we are currently. It was quite basic. But it was through teamwork that we are where we are currently. And I think it's really important for us to talk about Pat Seed. She was pivotal. She was a journalist from Manchester, was a patient of ours in 1976. I was 5 years old then. So in 1976, when she turned up to this hospital, the CT scan didn't exist. It was in the neurology departments. So she said, hang on, I've got cancer. You need to see what my cancer's doing, why you're not having a CT scan here. So it's too expensive for the NHS to buy a CT scan. So she said, why don't we just raise the money from the public? Because clearly everybody wants a CT scan. But the law, the 1948 law, did not allow hospitals to raise money to buy equipment. And it's fascinating that in 1948, everyone thought only the NHS could buy equipment. Hospitals couldn't buy their own equipment. So she's pivotal for all of us sitting here to have the equipment that we have through appeals. So she actually changed the law. Think about it. In 1976, she went on a campaign, changed and lobbied for the law to be amended so that we can actually raise money to buy high-end equipment. It's quite pivotal. So by 1979, so within 3 years, we had a CT scan here at the Christie. And think about it, it was only invented in 1972. And I think that's what the Christie Charity does. It gives this NHS Plus advantage for patients pretty early on. So it gets really novel imaging and techniques available at the Christie before the NHS can actually afford it. And that's a key aspect of it. So from her hard work, we actually have a radiology department named after her. It's called the Pat Seed Radiology Department. So if you walk along the main corridor, you'll see it on your right-hand side from this side. It's because of all the hard work that she actually did. On the back of that, with some aspects of the residual funding fund that was in the Pat Seed Fund, we then developed the MR department, which you currently might be able to see. It's got 4 MR scanners in there, and it had the first 3T scanner, which is supported by the charity. Why? Because 3T scanning is actually quite complex, and the charity said, you know what, we should have one of these here. And I said, I agree with you, obviously, being a radiologist, and we purchased that through charitable contributions. And what was really poignant, we got Pat Seed's granddaughter to come and open the scanner for us, the whole department, and that was quite nice. It's a good touch, because we keep the legacy going. Her grandmother put so much effort into building this change in legislation, which allowed many different hospitals to get the benefits of scanners. We didn't stop there. We then built an integrated procedures unit, the fluoroscopy machine that I showed you, that does the intervention. So rather than patients go to many different parts of the hospital, we had an integrated procedures unit custom built for patients here at the Christie, so they get most of their procedures done within that same department. And that was done in 2017. And we didn't just stop at building imaging, we built therapy centers. So the Proton Therapy Center, even though it's NHS funded, the research arm of it comes from the charity. So it actually enhances the proton therapy therapy center with added research onto it. And MR Linac, this is using remember I talked about hybrid? This is using MR and a linear accelerator to treat patients so that the accuracy of treatment really improves. Now, we were one of the first 7 sites in the world to acquire this machine. The only other site that's got this machine is in the Marsden. I was involved in this because the MR aspect of it is my specialization. And I said, we definitely need one of these machines. So everything that we are putting our money into actually comes in a roundabout way back to supporting something else. So when you have high-end therapeutics, you need high-end advanced imaging to actually make it work. So it's like a jigsaw puzzle that we keep putting together. We don't just go buy the nice new model every time. That is a waste of money. We actually categorically sit and think through our processes over 10, 15 years. So the planning is long-term. And what about the nuclear medicine department, which is quite dear to me, because I work there quite a bit. So we had the first SPECT-CT machine here installed in 2008 through a charitable appeal. And I've got one of my previous dentists here who actually reminded me when I went for an appointment that what we do here actually gets published in the community. He said, Prakash, I see your name here in the Jewish Chronicle because our people invested in your project. So it is about community. It's about building community links and actually giving back to the community. So the first PET-CT for the northwest of England was bought by the charity again in 2007. So that's pretty early on. And molecular radiotherapy, which is when we give the radiotherapy particles to patients, we were one of the first units in the country under the ENAT's banner to actually give comprehensive imaging and therapy in one department. Let's talk about ENATS. ENATS is European accreditation. And since the last 2 accreditations, again, we don't say these things aloud because I think we are humble. We've been rated as one of the best centers in Europe for tertiary therapies. So patients who are sick outside our region, including Europe, come to us to get treated. And we just get on with the work. And none of this could have been achieved without the Christie Charity. And that's quite how pivotal all your work and our work is, to actually make this the best place for you to come and get treatment. So, I like this slide. Who can do all the above? The therapies that we talked about, the advanced imaging, systemic therapies, which is chemotherapy, molecular radiotherapy, and cancer surgery. Only 2 sites in the world can actually deliver all of this. That's here in Manchester and in Amsterdam, not London. Now, when would you ever have seen that slide go up in the last 50 years? That's because of all the hard work we do as a group, as a team. So it's quite hard to actually achieve all of those things in the last 18 years, flat out. It's like from a standing start. And I'm quite proud of that slide because that is, you can Google it, you can put Google proton therapy, ML-Linac, which 2 sites, it'll come up with Amsterdam and us. And why do we do all this hard work? It's because of the research that we do here in Manchester. And we've got all the research academic, I'm so glad that they're here, the academic team are here as well, and the clinical team. It's about collaboration. So by investing in ourselves and actually working together, we're able to do better quality research, really high-end research. So if you look at our research publication, we're one of the top research publication centers in the world. Again, we don't talk about it. You don't see that news in Manchester Evening because we've got work to do. We're one of the busiest cancer centers in the world and one of the largest cancer centers in Western Europe. Again, you don't hear about that because we just get on with the work. But the pattern is quite key. It brings all of us together. So there are clinicians, there are research people, there are research scientists all sitting in the same room. That was the concept. The concept is if we get everyone sitting together, somebody comes up with a bright idea, they can enact it much quicker. Because they're sitting, the neighbor is the person who can do the next bit of the work. So it's quite important that the pattern comes up. When will it deliver results? It's already delivering results as we speak, but it's a huge future investment. It is going to deliver a lot, especially in the future, because it's got the facility now to bring patients in and clinicians and researchers in one place to work and deliver this kind of level of work that we're trying to do here. So that brings me to today's appeal, whole body PET. I'm going to say that's the next step in the future of imaging. It's quite a bold statement. If you looked at my initial statement, I said if you had a telescope and you looked up in the universe, you see different stars depending on how much power the telescope has. This has got an incredible, I've been doing this for 20 years now, so I don't really get excited about technology, but I'm quite excited by this technology. I wanted this like yesterday. So I'm so grateful that we are able as a group to deliver this to you by September next year, maybe? Yeah, so Heather's going to go through that. So we've got 2 companies that do these machines now. UIH, which is the company that delivered its first PET-CT, total body PET-CT system in Sacramento in America. We've made a visit to that department as well. And it delivers quite amazing capabilities that we currently can't do. And we'll talk about that very soon. Heather's going to go through that in detail. So then I'm left with closing remarks. So advanced imaging is a core part of the patient care pathway. So these abilities in advanced imaging allows the Christie to deliver cutting-edge diagnostic, therapeutics, and clinical trials to our patients. And the Christie Charity plays a key part in all of this. All of us, play a key part in all of this. So the total body PET clearly is an exciting and innovative technology that we wanted yesterday, but we're going to be getting it very soon. So we're looking forward to delivering this technology to you. Thank you.
Good morning, everyone. I have also a slide to introduce me. I did mention to some of the colleagues from the Christie Charity that this appeal has got a particular resonance for me because that fresh-faced physicist in a lab coat in the left-hand picture is me doing my PhD with the first PET scanner in Manchester, which was also funded by the Christie Charity. Its successor, which is the one in the picture, which some of my colleagues may recognise themselves in that picture. You can just see me peeking over the top. That was when I came back to the Christie after 13 years of working at Manchester Royal Infirmary as a medical physicist there. And now I've seen the service continue to develop and this particularly exciting development on our doorstep. So I'm a physicist by background. I did physics with medical physics at Nottingham and then did a medical physics orientated MSc at the University of Manchester as part of the NHS scientific training programme and did a PhD in PET on that very scanner with UMIST. I don't know if anyone remembers UMIST. I insisted on wearing UMIST robes at my graduation. I was the last set of students to graduate from UMIST. And I'm a state registered healthcare scientist and again a registered medical physics expert with a particular expertise in nuclear medicine research protocols. So unlike Prakash, who has jet-setted everywhere, I have spent my entire career in Manchester and I have not felt at all limited by that decision. It's one of the finest cities in the world, in my opinion. And I trained here, did my PhD here at the Christie and went to work at Manchester Royal Infirmary where I oversaw the development of several aspects of the PET-CT service there, including their paediatric and cardiac work, which is their area of specialism at present. And I came back to the Christie in 2018 and started developing the postgraduate education programme, which feeds into the PET Academy work that we do, then head of physics, head of nuclear medicine, currently clinical director for medical physics and engineering. And the medical physics and engineering workforce underpins all of the technological developments that Prakash has spoken about. So the people in my current team work in protons, work in MR, work in CT and work in nuclear medicine. And it's one of the largest medical physics and engineering workforces in the country. I'm also involved in several initiatives at national level. I lecture at postgraduate level in several local universities. And this is a dangerous thing to say, isn't it? I am genuinely an award-winning science communicator, which is risky when I'm about to try and communicate some science to you. That's what the MBE is about. My particular research interests are the development of PET technology, and one of my colleagues is actually at York University today talking about how we can improve how the detector within PET works. So the cutting-edge nuclear physics research is translated into the clinic through those kind of collaborations. And also in the development of novel imaging and data analysis methods. So we've got this wonderful technology. How do we get the best out of it? How do we deploy current techniques in novel ways? How do we develop new tracers, new techniques, and translate those into the clinic? And we also, as you're well aware, Manchester, the home of the first computer, have a very strong interest in AI and deep learning, and there is a medically focused big data group across the road in the Patterson for us to collaborate. So there's lots to go at in terms of all the kind of nerdy stuff that's definitely my cup of tea. So Prakash has touched on PET-CT. The CT bit is probably more familiar to most of you, so I'll start with explaining how that works and why that's important to us first, before I get on to talking about PET in detail. So, bit of a schematic diagram. The CT essentially involves taking lots of x-rays from all the way around the patient by having an X-ray tube that rotates as the patient goes through the middle of the scanner. So it's all medical imaging systems looks like donuts, which is tremendously confusing as a patient because it's just another donut and it's got something different inside. That the tube goes round and round and round and round, and if anyone's had a PET CT scan, you know that you go through as that's happening. We keep the covers on. If you want to terrify yourself, please do Google CT scanner covers off, and you'll see exactly how quickly that tube is going round to acquire these pictures. Nice stroke scary videos on YouTube if you'd like to look at them. So we end up with a lot of these essentially X-rays from all different angles, and then use rather more up-to-date computer than that, and lots of maths to put together a series of cross-sectional images. So the computing bit is how we construct a 3D map of the structures of your body from all of that X-ray information. The tomography bit is from the Greek for slice, tomo, which means that you get a series of slices through the body, and that's where tomography comes from. If that ever comes up in a pub quiz, you heard it from me. This is the inside of a PET scanner, and also younger me. This particular picture did the rounds with one of the manufacturers with their sort of sales team for years, because it arrived and I literally hugged it because it's one of the most beautiful things I've ever seen. Yes, I am strange like that. And inside, yeah, I'm going to need a really big cuddle for that one. We'll get onto that in a minute. But inside this sort of, again, just another donut, this is what's going on. If we take our example of, again, that slice through the patient, that pink ellipse, this is not to scale, by the way. These things are happening over a sort of sub-millimetre at times, certainly within a couple of millimetres, these interactions. The way nuclear medicine works is that we take a drug that goes through a particular process in the body that we're interested in studying, and we take a tiny amount of that drug so it doesn't interrupt that process, it just kind of goes along with it, and we tag on something that gives off radiation to that drug, and that's called a radioisotope. And that radioisotope is essentially there to provide us with a signal so we can see where that drug has gone to in the body. So in some of the scans we'll be talking about, we'll see more of this drug, this radiotracer, in the areas of the body where that process is upregulated, and less of it where it's not as active. So after if you've ever been to us for a PET scan, you'll have had your injection, you have a wait while the drug travels around your body and settles where we need to see it settling. And that, in a PET scan, that radioisotope decays to emit a positron. And the positron is the antimatter version of an electron. And so when it runs into an electron inside the patient's body, because you've got matter and antimatter coming together, it's all a bit Star Trek. This is actually what powers the warp drive, by the way, apparently. That you bring the matter and your antimatter together and you get a burst of energy. In physics terms, this is called, all of the matter that's bound up in that positron and the electron is converted into energy. And you get two back-to-back gamma rays coming outside of the patient. And then gamma rays are just a sort of naturally produced version of X-ray. And what we're doing in a PET scanner is collecting thousands and thousands and thousands of these gamma ray pairs during your scan. And if we can map back along that line defined by those two gamma rays, we can say, okay, positron met the electron somewhere along that line. Therefore, our radioactive molecule is somewhere along that line. And we use all of these thousands and thousands of lines in a given scan, again, going through rather more fancy computers, rather more fancy maths, to build a map of where those radiotracers are within the patient's body. So that's the PET bit. We put it together with a CT, and there are loads and loads of PET CT scanners. It's actually quite hard to buy a PET-only scanner now, because the acknowledgement is that actually it's really, really useful to have the CT scanner and the PET scanner in that same donut, because you get that structural information from the CT, and in the same scan, because the patient doesn't move, they lie on the same bed, and the bed moves between the CT bit and the PET bit of the scan, you can actually overlap where all those radioactive drugs have gone on your CT. So you've got a structural map from your CT, and you've got a map of how active that function in the body is from your PET. So it's an incredibly powerful technique because you can not only see the shape of the body, but how well it's working or not working, depending on which drug you choose. So this is an example of a scan from one of our patients who's been to us for a lymphoma scan. Before treatment, we're seeing an upregulation of this FDG injection, which is, you know, one of the most common injections we use. It's a form of sugar, and because tumours are growing really, really quickly, they're quite hungry, so they take up all this sugar out of the bloodstream to fuel that growth. And so we see a higher concentration shown in the black in this image here, that image there, compared to the paler structures around them. And that helps us to see that, yes, there's quite extensive disease for this particular individual. If we do a PET scanner after their treatment, we can see that quite a lot of those sort of dark circles that we see in this big lump here in the neck, they've resolved as a result of that treatment. So PET is really helpful in defining the extent of disease and deciding exactly where it is. With the CT, we can say, okay, all these things in the sort of the lower half of the abdomen, where exactly are they? Which structures are they affecting? Do we need to do anything additional in the treatment plan to address those? And also to be able to see before and after treatment what difference we've made. And PET scans also, you can say, well, exactly how much of this radioactive drug is in that particular area in the body, so we can put numbers on this difference and quantify it and say how big a change has been made. And in terms of research scans, that's one thing we do quite a lot. We're saying how big a difference has it made, and look at those numbers in a bit more detail. So most of the work we currently do in Manchester, there's a PET scanner here, the ones in Wigan and Oldham, and with our colleagues at Manchester Royal Infirmary. Most of that network capacity is devoted to oncology diagnosis, staging and response assessment, as we see in these images here. In Manchester, there's a real interest in nuclear cardiology, sort of using PET to study the heart as well, which is the area of specialism that our colleagues in Manchester Royal really devote most attention to. But there's growing interest in studying the brain using PET, which is actually where PET started back in the 70s. It's kind of, again, it's one of those satisfying circular things. And the systemic inflammatory diseases, which we've got a useful example of later. So I've talked about PET CT. What is total body PET CT? You have your PET scanner sort of sitting behind your CT scanner. The patient sits on one bed, goes between the two. That scan can take somewhere between 20-30 minutes, possibly longer if it's a research protocol, up to an hour. And anyone who's spent any time on a scanner bed will know that that's not the most comfortable experience. With total body PET, in principle, it's actually a very straightforward thing. How about we make the PET detector really, really long in terms of how much it covers of the patient, so we can scan all of the patient in one go. But the benefits are not just that we can fit everybody in, about sort of 96-97% of people we can fit in one go, and we can still move very, very tall people along a bit like we do with our conventional scanners. It's also, if you imagine that the patient is sort of giving out radiation in all directions, if you could just imagine a light bulb roughly where your belly button is, go with it for a second. And you've got all that radiation shining out in all directions. If you have a PET scan that's about that long, you're only going to collect in one go the light that's sort of coming out from that section. If you cover all of your body in a PET detector, you're picking up the radiation from this point at the PET detector that's here and here and here and here and all the way around you as well. And that means that the longer you make a PET detector, the more sensitive it is. And if you make it much, much, much longer, it gets incredibly more sensitive compared to a standard scanner. And that means we can scan really, really quick, as well as scan everything all at once. The real world advantage of this is twofold. One is that conventional patient imaging can be done really quickly. And so being able to, the detector is 40 times more sensitive. It might be, 4 or 5 times longer, but the actual detector, because it's covering more of this patient, picking up more of the signal in one go, 40 times more sensitive. And because we can scan so much more faster, we can release up to 4 times more capacity. And we can, because we've got more capacity to scan patients, it also means that if we have a problem with a scanner elsewhere in the region, we can bring more capacity onto the Christie site and be more resilient in making sure patients are not waiting longer for their scans. That shorter scanning time is an improved patient experience. And also because a scanner is more sensitive, we don't have to give as much of the radioactive injection to them. So that in turn reduces the radiation dose to them and the associated risk. And because we can cover the patient in PET detector essentially, we can look at the injection as it goes into the body. And this is what this really lovely movie in the right hand panel shows. We've got this is a super fast routine clinical scan. It's just one point in time. This is lots and lots of PET scans, probably over the course of an hour or so, which shows the delivery of that tracer. And as a research tool, looking at how those drugs distribute within the body, that's incredibly powerful. And it's not data that you can get when you're scanning this bit and then this bit and then this bit and then this bit to build up an image like that over 20 minutes. So in terms of where this is going to go, we are here. So if you take a little stroll around the block, you will come to where I live in the nuclear medicine department. I'm currently still overseeing nuclear medicine before I hand over the reins of that department in a couple of weeks' time. And right next door to it is a dedicated imaging research centre that's owned and run by the University of Manchester. It has a cyclotron for making the radioactive materials, similar to the ones that we need in our injections in the basement. And that we are in the process of partnering with the University of Manchester to redevelop that facility and the imaging facility within it. So this is our current outline plan for what that facility is going to look like. It's essentially an architect's first draft based on many, many years of discussion. The PET scanner is here. Lots and lots of places for patients to wait while they're having their scan, because they'll be going through the scan very quickly, and a reception area and other patient support areas here. I've got some initial drafts of what that's going to look like from the architect. So this is the reception area with its nice sort of open round reception desk is our initial idea of how to make best use of that space. And the PET scanner here, those of you at the front rows might notice that it looks like it's been cut out of cardboard. And that's because we haven't made a decision about which scanner we're buying yet. We're still in the procurement process, the tender evaluation process. So I've got an example there of sort of, it is going to be a total body PET scanner. We haven't got any more detail than that, but at the present time. I just wanted to throw that really, really busy slide in front of you just to highlight the research opportunities that are available to us. This is part of a grant application we put in a couple of years ago, and all of the networks we explored in Manchester, in the Northwest and beyond, opportunities for collaboration and for novel research on this particular scanner. We have so many conversations and so many exciting projects to look after. My predecessor, who some of you may have met, Ran Mackay, was key in bringing protons to Manchester and developing the proton beam therapy facility. Essentially, total body PET is my protons. This is going to be at the top of my to-do list for the rest of my career. hopefully that explains a bit why this thing is so fantastic. I'd like to invite Prakash up just to talk through a couple of examples of particular patient studies which have been published recently in the scientific journals.
So,
to you, Prakash.
Excellent. So you're going to get a double whammy here. So this is how we work. We work as a collaborator. So physics, clinics, the doctors working, physicists working with our staff members, deliver care to the patients. So I think of all the slides we've done so far, this next slide's quite important. Sadly, these two kids, a 9-year-old and a 3-year-old, both have lymphoma. Both these kids were scanned in a different center on a total body PET scanner in less than 4 minutes, or approximately 4 minutes. Currently, it would take us 20 minutes to get them in there. So imagine trying to keep a 3-year-old quiet in a scanner for 4 minutes. You can't keep them quiet for 25 seconds, right? So this has changed things quite dramatically for them. What's even more important, as the kids get younger, including that 3-year-old, they have to get general anesthetic. And that was a key thing for us. When we went to Denmark to look at their facility there were 1-year-old babies being scanned with no anesthesia. The mother would feed the baby, put the baby in the scanner, and as they start the scanner, the baby goes into a sleep mode, and within 5 minutes, they've got all the information. In the past, when I used to do these scans, we used to spend 3 hours trying to scan the child. Because the first hour was spent putting the child down into the anesthesia, doing the scan for 20 minutes, and then getting the child back out and recovering the child in the department for another hour. So the entire scanner was blocked out for half the day for one child. And the risks of anesthesia. So for me, this is the most important slide that we have. So what are we showing here? In one scan, we can pick up all the lymphoma sites right across in 4 minutes flat out. And what these kids will get will be a repeat scan in a few months' time. So imagine the experience with an older scanner, where they'd say, "Mummy, it took me half an hour to get in there." The same mum is going to have, or parents are going to have less of a resistance from the child when they say, "Remember the last time you went to the Christie and it was there for 4 minutes?" We'll obviously give them lollipops after the scan, not before. But these are the kind of things we have to consider, and you can see the list of things it's going to do. It's half the dose, which is really important because these kids are going to live to adulthood and longer. So less dose at any time point of their pathway is crucial. And we're talking really low doses. And Heather and I have seen images. Half dose is probably an overestimation now. We've seen 1/10 the dose being given to the kids and still getting diagnostic scans.
And that's all as a result of the longer you make a PET scanner, it gets, in the case of these systems, 40 times more sensitive. So that means you can collect all the data you need in a shorter period of time and with much less of the initial injected activity. Our colleagues at the Royal Free in London have already used these scanners to image pregnant women as well. And we would not normally consider that for a PET CT in pregnancy because the radiation dose is so high. But we'd be able to reduce the doses so low for just 2 individuals so far that actually they've been able to have life-saving treatment during their pregnancy, which is generally groundbreaking. We wouldn't really want to do that with the current scanners.
That's correct. But in the University of Michigan, we used to do pregnant women, but it was quite invasive. We had to put a catheter into the bladder so that the dose gets drained very quickly from the baby, and put the mother in a sideways position and leave the mum there for 40 minutes in the scanner.
Yeah.
It's remarkable what's
not the
happened.
same.
It's not the same. Okay, so the next slide. So that's the first one. Next slide. Heather's going to take the lead on this one first.
Yeah, so this is, I talked about FDG as a form of sugar. This type of injection is something called PSMA, which is prostate specific, I always struggle with that word, membrane antigen. And as the name suggests, this targets prostate cancer. And it's an established tracer. We do a lot of these scans in Greater Manchester every week. But this particular example is looking at how that that radioactive injection circulates through the body, and it's just pulling out those little subsets of that data. So we've got an hour of the patient being on the scan, which I appreciate is not a insignificant commitment, but to look at the delivery of these tracers, perhaps in looking at, is there something else going on in the body that's a bit more subtle than we would see at the image at 60 minutes. We typically image these patients at 2 to 3 hours after injection. So we just have that one image at the bottom is usual. But if we collect all of these images, we see the development of that pattern over time, and how much is that pattern influenced by the blood supply to various areas of the body? How is it influenced by the fact that there's uptake in other structures apart from the cancer? And this is a really important research tool. If you can imagine doing this type of imaging with a drug that was unfamiliar, that you weren't exactly sure where it was going to go in the body, you can label a very tiny amount of it with radioactivity and see where it goes, see how the body processes it in real time. And for drug development and for developing new radioactive injections for these kind of applications, it's such a powerful system, being able to see effectively all of the body, all of the main organs of the body anyway, in one go. Do you want to add anything?
Yeah, just a quick addition, just to remind people that from there to this area here, it's all done in one view. The patient this is what we're seeing. Previously, you'd have had to put a jigsaw puzzle up together, but that bit is then linked with that bit, and then it's then linked to that bit. Literally, the patient goes through little step by. So that's a big difference. We now can see the entire body in one go, actually being able to work out exactly what's happening. The heart, in the kidneys, in the bladder, in the liver, in the spleen, all at one go. Unprecedented. So I really rarely get excited about scans, but this one I am quite excited about. Just as the wrap up, where's this patient's tumor? These are all, can you see the small little nodes that we're looking at? These are all the sites where the tumor is metastasized to. Now we know where they are in absolute detail within, this is a research scan, so this would have taken an hour, but just take this part of the final part of the scan, it would only take us 4 minutes now to actually find out in absolute detail where every single part of the tumor has gone to. So it gives us a deep insight into the biology of the tumor. And that has not been done before. We actually don't quite know what is the absolute potential of the scanner yet. It's only been around for 5 years. So I think it's going to, without hyperbole, nearly limitless for us to actually try and get there when we start doing more research in it. Now, so the last slide. So I understand that we are sitting in a cancer centre, but I see our society as Manchester. So we need to put something back. So Professor Cool that I spoke to you ages back, he was a brain expert, a huge brain expert. And he worked on the brain for many years. He deciphered how Alzheimer's disease and different types of dementias worked using radio tracers, which is what we're seeing being taken up in the brain. Now, we can utilize the same scanner for the community of Manchester, looking at diseases that are caused by inflammation by using total body PET. Again, what it does, it allows us to see from the vertex to the toe in most patients and look at every single part of the joint that these diseases tend to affect, and also look at all the vessels that these diseases tend to affect, and get an idea where everything's happening at the same time. So we have quite a number of our research projects planned around inflammatory diseases. Previously, this was quite impossible or difficult to do. The only way we would be able to study what's happening in the knee is to move the camera all the way down to the knee and then do a biopsy of that particular area. So we are trying to get away from biopsies. We're trying to use the tracers as a surrogate. Currently, we still need biopsies, but we're doing a lot of research where a lot of invasive interventions by medicine has been replaced by scanners, by using molecular imaging. So to me, again, this is a very important picture. Why? Because patients with cancer have other diseases, heart diseases, as Heather was talking about. We have not done enough investigations on how heart diseases come about. So these kind of scanners give us an opportunity to try and delve into that a little bit better. And it's the higher sensitivity. We can get so much of this information so quickly. The data is so large, we need literally supercomputers, and that's why our colleagues here from Manchester University are here. We literally need to use our facilities to decipher what we're looking at.
So I think this is a really lovely example of that ability to see all of the systemic disease all at once. Because if you have a condition like arthritis, typically doesn't stay in just your hands, in just your feet, in just your knees. It affects all of your body. And research I did just after my PhD shows that people who have inflamed joints have inflammation elsewhere in their vessels, which makes them more vulnerable to heart disease. So being able to look at this whole picture of what's going on inside a patient all at once, and we can acquire those images like that movie I showed you before. We can see that picture developing over time. That's such a rich source of information about how that disease is developing and how all of these different bits of the body are interconnected, and how we can deliver treatments that treat all of the disease, not just one thing that we see in one set of pictures. I think that's it.
Thank you.
Thank you very much.
Thank you.
And just to bring all of this wonderful theory and exciting ideas back into the reality of patient experience and practice, just like to invite John McCormick up. John is what we call in our nuclear medicine department a frequent flyer. I was joking with John earlier that we maybe should have one of those little loyalty cards where you have so many scans and you get a free cup of coffee. It's the least we can do. John has been with us for 14 PET scans in the course of his participation in clinical trials, and also for assessing how he's getting on with his cancer treatment. I think it really welcome his perspective on the difference this kind of technology is going to make to him and patients like him. So John, over to you.
Thank you. Thank you. Well, I don't know about you, but that was quite a revelation to me. And as a patient that had gone through biopsies after biopsies, and some of them quite painful, and other biopsies that couldn't even be performed because they were in places that were just too risky to get surgery into those areas. It was really enlightening and also very encouraging as well. I'm blown away with that. Thank you. Thank you. Well, yeah. Are we loaded? Okay. Right. Yeah, well, you already know my name's John McCormick, and I just feel very happy and very blessed to be here. Here in particular, because I wouldn't be here without the expertise and the care, that expert care of the Christie. This is my latest portrait, and prior to this, I thought I could look quite well, but obviously not in the eyes of my grandchild. There we go. I was first diagnosed with non-Hodgkin lymphoma way back in 2002. It's a strange disease. My treatment had already been agreed when I experienced a spontaneous remission. A remission that endured an amazing 15 years until my lymphoma transformed into a more aggressive form and my health deteriorated very rapidly. Then followed a series of harsh conventional chemotherapy treatments. Initially 7 cycles of R-CHOP, and 12 months later, after relapse, 6 weeks in an isolation ward, receiving a stem cell transplant, and then just for good measure, when that failed, a now abandoned clinical trial named ME401. As you can see, none of these medical interventions provided a lasting remission. And by late 2020, lymphoma was most definitely gaining the upper hand. I was in a poor state of health, with an immune system so weakened by disease that I had 2 episodes of sepsis. I was a mere shadow of my former self, and my future looked both very brief and very bleak. This is me, 6 feet 1 inches tall and well under 10 stones in weight. And that's how I presented to the Christie. The optimist in me had most definitely gone into hiding. But it was at this low point in my life that Christie appeared on my horizon, and it supplied me with new hope. Following tests, I was fortunate enough to be accepted on a new early phase immunotherapy trial treatment led by Kim Linton. You know, it's been said in the other by the other speakers, we're so very lucky to have the Christie in our region. Of course, we all know that it's a well-deserved reputation for cancer expertise and research and care, but it is so much more. A warmth radiates from all its people, from most senior to most junior, from consultant to cleaner. Most importantly, it displays a competence that implants confidence and hope in all its patients. Incredibly, after 6 weeks after starting my immunotherapy treatment, my cancer was in retreat. And even more incredibly, after 12 weeks, my scans revealed that my lymphoma was in complete remission. A remission, I'm very pleased to say, that persists today, more than 4 years after I started treatment. These are PET scans. I've seen a lot of those before, and the one on your left shows me as I presented and the widespread disease, and the one on the right after 12 weeks of treatment. During my 4 years, over 4 years of treatment at the Christie, I'm reliably informed that I've had 14 PET scans and 14 CT scans, and I quite probably qualify for the most irradiated man in the world. But on a serious note, PET scans play a pivotal role, as you've all heard. Pivotal role in the early detection of cancers, the measurement of the progress, and tracking the efficacy of treatments. My own PET scans take a minimum of 1 hour preparation and around 25 minutes in the machine. Anything that can speed that process and make it available to more patients just got to be welcomed. New scanning equipment can fulfill that need and also improve the scan quality. I'm one of the lucky ones. Almost by serendipity, the Christie found me, and clinical trial made the drugs and periodic scanning a reality. How have I progressed? Well, by June 2022, less than 18 months after starting treatment, I was strong enough to walk a 130-kilometre section of the Camino Frances, a 9th century pilgrim's route to Santiago de Compostela in northern Spain. In 2023, I completed another Camino route to Finisterre, which literally means the end of the world, and then to Murcia, beyond the end of the world, on Spain's northwest Atlantic coast. And last year, I completed 200 kilometres of the Camino Portugues, coastal route from Porto to Santiago. This year I've walked volcanoes in Lanzarote, and I've explored sections of domestic long-distance footpaths. This is me, footsore but happy, outside the cathedral at Santiago. In addition to celebrating my return to good health, my walks have also raised funds for the Christie's vital research and treatment programs. The Christie and supporters of the charity like you have given me my life back. And I shall be forever grateful. In 2023, my wife Jacinta and I celebrated our 50th wedding anniversary together with our 2 sons, grandchildren, family and friends. And in March this year, I celebrated my 73rd birthday. Just give you a... Oops, what's gone wrong there? There we go. That's a slide of my famous dad dancing routine, I believe. Yes, yeah, that's right. Each one of these events were doubtful possibilities before I attended the Christie. But now can look forward to a future filled with all the normal activities and the adventures that my cancer tried its best to cancel. I dearly love all other cancer patients to enjoy the benefits and the first-class cancer care delivered by the Christie. And I'm sure that as supporters of the charity, you all share that view. This is the sunset over Muzia, the beautiful sunset over Muzia. It's at the end of my 2023 Camino. And it also marks the end of this little presentation. Thanks for listening to my story. I wish you all a very successful 2025, full of joy and hope, and of course, most importantly, robust good health. Thank you.
Hello everyone. The eagle-eyed among you will notice I am not Bod Buckby. Slight height difference. I just wanted to say thank you so much, first of all, to John for that wonderful presentation and for sharing your story with us. It makes such a difference to be able to do that with supporters and visitors. And a big thank you as well to Heather and to Prakash for that incredible presentation. I think everyone was just, shell-shocked maybe, might be a good word. Such a wealth of information, and it's so exciting that we're able, as the Christie Charity, to support getting the new total body PET CT scanner. We are pretty much bang on time at the moment, but I'm happy to do, I think we could fit in maybe 2 questions, if there were any. We have to keep it. Sorry, we have to keep it really short, Janet. If that's okay.
No, very quick. I'm a layman person on all this, but what question I'd like to ask is, if anybody's got anything in their body, like plates or a loop, I've got to make a decision on something, whether I have something put in for my heart. But I want to make sure that it doesn't affect. I've been diagnosed with a tumour in December. So I want to know whether the loop's going to make a difference, because I've had the scans, and so I'll stop there. If you're having any scan, I mean, how does it affect? Thank you.
I'm quite
Thank
happy to speak to that from a sort of technical perspective. And then Prakash, I don't know if you've got anything you'd like to add. So it is something that our teams do check, because if we have with PET scans or CT scans, we've got this radiation coming out of the body, or we're shining X-rays through, and we want to make sure essentially there's not a gap in that information, because whatever implant you've had done is blocking the information coming out. The really probably reassuring thing to you is that there's enough information coming out other ways out of your body for us to still be able to see what's going on. So yes, if you've got something implanted here, the signal we detect over that might be slightly less, but there's so much information coming from the rest of your body that we don't miss anything. So you don't need to worry about that. The only other thing that they might ask a few more questions about is if you had an MRI scan, because MRI scans can interact with pacemakers and things. They just need to make sure it isn't going to change that, the settings essentially. But we can do pretty much everything safely and find workarounds for that, so don't worry about it.
I've already had the MRI scans.
Yeah.
I've already had that.
Yes.
So it's just future.
Yeah. We get enough information from the rest of your body and we can work safely with whatever device you have put in.
But you just mentioned it.
Yeah.
Will you have all the information, or do you ask your patients?
Generally, we do have information, but we always check to make sure we've got absolutely everything accurately. So there will be a conversation with you. Yeah.
Oh, thank you.
Not to worry. Prakash, did you want to add something?
Yeah, I'll just quickly add. So from a PET CT scan point of view, I didn't think I was going to use this. The AI changes now, the artificial intelligence machines that we currently have actually reduce some of the streak artifacts. So we actually get even better detail. So from a PET CT scan point of view, very few things contradict. So you can definitely get the scans, not an issue. You can get follow-up scans, diagnostic scans, not an issue. From the MRI point of view, a lot of the machines that we put into patients now are compatible and are safe with future MRI scans as well, depending on your heart condition to a certain extent. But we will be able to find ways around to try and scan you, which is why I showed you this initial picture with all those different scans. That's why one scanner just doesn't cut it. So we do need different scans. But I'd say of all the scans, the whole body PET scan is probably one of the more innovative ones with the artificial intelligence already in there to try and reduce any artifacts. So I would confidently get your permanent pacemaker put in. It's quite important because that keeps your heart going well, so we can continue doing all the scans safely.
I'm just looking to the future, you
No,
see, so I'm
yeah.
not just...
Agreed.
Yeah.
So but we don't see any issues
That's
with
really
that.
helpful. Thank you, all of you.
We've got time for one more. Were there any more questions? Oh, yep, it's late in the middle here.
I thought those two presentations were remarkable, absolutely splendid, mind-blowing. And it made me wonder what Madame Curie would think about radioactive isotopes being used as diagnostic tools these days. And not only your patients at the Christie, but all the countless non-cancer patients that are being treated in that way for things like thyroid or parathyroid markers. The whole thing is just beyond real. Thank you.
Thank you so
Statement,
much.
not a question.
At scientific conferences, that's normally prefaced by, it's more of a comment than a question. But it's very, very welcome, thank you. I think actually Curie would have been quite confused by all this because her own interactions with radioactivity didn't end well, for those of you who know her story. The understanding of radiation was not what it is now. And the use of it was frankly unsafe in her time because she was discovering it. She didn't know what she was working with. And she ended up dying of leukemia as a consequence of her radiation exposure. So I think if we transplanted her back from her day into ours, she would say, what, you're putting radioactivity into people? What are you doing? But we know it well and we understand it well and we can use it safely now. And the amount of radiation that we use in each of these tests as the technology improves just goes down and down and down. So we continue to proactively reduce what is already a very, very small risk. So yes, a cup of tea with Curie would be something I would very much look forward to if she were here.
I think that's all we've got time for, but if you do have more questions, I'm sure not to put them on the spot.
Yeah.
People can come up and ask afterwards if they'd like to, or you can send them in to the Christie Charity and we'd be more than happy to pass them on to Prakash and Heather and John. And it just goes for me to say thank you once again for coming along. I hope you really enjoyed that session. Please feel free to fill in a feedback form or speak to a member of staff outside if you've got any other questions about the charity and what we do. And hopefully we will see you at the next Spotlight event. Keep an eye on our socials and website for details. Thank you.
Thank you.